Shall we start?
Yeah.
Good morning, everyone. Good morning to Dr. Stein and my fellow friends. I'm Dr. Kohr, and you can call me Bao. And the topic that I'm going to present today is sudden unexpected death in epilepsy, which is also known as Sudep. And for the purpose of this presentation, I'll be using the abbreviation Sudep throughout the presentation. And before I get started, just a brief introduction about myself. I'm raised and born in Malaysia. It's a very small country in the Southeast Asia, and it's a country that sits between Thailand and Singapore. And I received my education back in University of Malaya as a medical student. And it was founded many years ago, back in 1905 in King Edward VII College of Medicine, which then combined with Raffles College to become University of Malaya. However, in the year of 1962, it was split into University of Singapore, which is also known as the National University of Singapore right now, and University of Malaya. And we have our first batch of medical students back in the year of 1964. And currently, I'm doing my Master in Medical Science project, which is also in Sudep. And that is the reason I'm going to share more about Sudep today. And before we get started, I just want to share a case of a patient of mine who unfortunately passed away due to Sudep. And she was a 32-year-old lady with temporal epilepsy since 25 years old. She had a history of uncontrolled seizures back then, and she had generalized tonic-clonic seizures, nocturnal seizures, and she was on multiple anti-seizure medications. Before she passed away, she stayed with her husband, daughter, and mom. And investigation like MRI, EEG was done, showing bitemporal hyperintensity and discharges. And the reason I'm highlighting these features is because all these features are features of Sudep. And at the time of her death, she passed away at home, and it was unwitnessed. And her family member reported that she was well before the sleep. And when they noticed her at her bed, at a prone position with the face on the pillow, and when she was turned over, there was drooling of saliva, and she had no response. She was sent to hospital. However, she was pronounced dead at hospital for more than 1 hour. And there was no autopsy done. And that's why I think that it's a probable Sudep. And for the following slide, I'll be explaining what's the difference between probable Sudep and Sudep in terms of definition. To diagnose Sudep is not easy because you need a lot of criteria and also an autopsy which does not reveal a cause of death. And in order to diagnose Sudep, it has to occur in an individual with epilepsy in the first place, and it has to occur in benign circumstances whereby the death should be non-traumatic and non-drowning death, which is sudden and unexpected. And that's why it's very difficult to diagnose Sudep. And the biggest difference between Sudep and probable Sudep, which we thought our patient have, is probable Sudep does not need an autopsy. That's why we call it probable Sudep. Otherwise, the criteria is the same as Sudep. And why do I talk about Sudep, since it's something like not commonly known among doctors or even neurologists? And there are 4 reasons which make me want to share it today with all of you. And the first reason being is one of the most common epilepsy-related deaths in people with epilepsy. What I mean by epilepsy-related death is that it encompasses death caused by epilepsy directly, which is status epilepticus, or it can be drowning due to epilepsy, traumatic injury causing death due to epilepsy. These are epilepsy-related deaths, and so that is one of the most common epilepsy-related deaths. That's why I wanted to share Sudep with all of you today. And the second reason is underdiagnosed. Like I said earlier on in the previous slide, is because you need to meet a lot of criteria in order to diagnose Sudep. And many doctors don't even know what is Sudep, so that's why it is underdiagnosed. And it is largely preventable because Sudep has a few risk factors that is modifiable. And by modifying the risk factor, we can actually prevent the Sudep. And I'll talk more about the risk factor of Sudep at the end of this presentation. And the last point I want to make here is that Sudep is not commonly discussed with patients. And I'd like to share one article with all of you about this. And this article is about a global survey of neurologists' opinion on Sudep. It was done back in 2020, which is last year. And they gathered 1,123 neurologists across 27 countries. And they found that there are 41.5% of the neurologists who rarely discuss the risk of Sudep, which is half of them, almost half of them. And the next question, important question they will ask about is that they do not discuss about Sudep with the patient because they're afraid that it will induce anxiety to the patient and their caregivers. And it is up to 42.6%, which is almost half of the doctor in this study. And that's why I believe that this is something that we should address and we should make it more well known among the patient. And it's important to let the patient know what Sudep is all about. And I will talk about the counseling towards the end of this presentation. Just a little bit of background of Sudep. I'll start from this incident of Sudep. I would say Sudep is not that common to begin with, and it's less common in childhood, which stands at 0.22 per 1,000 patient years. However, it increases in the adulthood, 1 to 1.2. And I have another graph to show why is that so. And as we can see from this graph, it's a graph taken from a study back in 2040 done by Dr. Thurman. So from this graph, we can see that there's a trend of increasing Sudep cases as the patient age until 21. And after that, the trend decreases as the patient age. As we can see from the graph, it works like this because one of the probable explanation for this trend is because as patients grow older, especially after 50 years old, to diagnose Sudep is not easy because usually this group of elderly patients, they have some competing causes of death like cancer, respiratory illness, or cardiovascular disease, stroke, and so on and so forth. So when they pass away at that time, the most probable cause of death would be written as all these competing causes instead of Sudep on the death certificate. Whereas on those patients who are aged from 21 to 50 years old, the most probably underlying medical illness they have at that time is just epilepsy. They don't really have those other comorbidities. So that's why when they pass away, the only probability that we thought of is Sudep that caused them to pass away. So that's why you can see a trend of most of the patients like this 21 to 50 years old young adult age group will die of Sudep. And speaking about the mechanism of Sudep, there are a lot of studies that propose the mechanism of Sudep in such way. It can be caused by ictal hypoxia, dysfunction in subcortical and brainstem. And there is one landmark study done many years ago. It's called the MORTIMERS, which is Mortality in Epilepsy Monitoring Unit study. In this study, they observed and described how Sudep started from the beginning to the end. And it started off by generalized tonic-clonic seizures, which then alter the respiratory and cardiac functions, and it can lead to immediate death. Or if not, a short period of partly restored cardiorespiratory function, then followed by terminal apnea, and then cardiac arrest. Although it is clearly described in this study that mechanism of Sudep is as such, however, till this day, still many studies are not able to identify the exact mechanism of Sudep, and it is very complicated. So this is the known mechanism, proposed mechanism we understand from this study. And from this mechanism, it helped many more studies in the future to explore the prevention of Sudep, whereby there are 5 of them on the screen right now. The first is reducing the number of generalized tonic-clonic seizure, which is part of the Sudep mechanism. And by reducing this, we can prevent Sudep. As for the second prevention, which is the monitoring devices, such as those cardiorespiratory vital signs monitoring devices are essential to prevent Sudep, because as we can see from the mechanism, the patient will have outer vital signs. By monitoring their vital sign, we can prevent Sudep. As for the third prevention, which is the nocturnal supervision or safety pillows, is also a way to prevent Sudep, because Sudep mostly happen in patients who are sleeping and at night. So that's why many studies have proposed that nocturnal supervision and safety pillows could be helpful in preventing Sudep. And the fourth prevention is by physical stimulation and serotonin reuptake inhibitor, SSRI. So by having these two, we can prevent Sudep in a way that it reverses the central hyperventilation which occurs in Sudep and make the patient aroused. And for the final prevention is to reduce the adenosine and endogenous opioid, because these two medications are medication that can potentially suppress the brainstem and the brain function. That's why by reducing both of these, we can prevent Sudep theoretically based on the mechanism. And I've found out an article on the treatment for the prevention of Sudep, and it is a systematic review published back in 2020. And in this article, they are trying to filter articles that focuses on the treatment for prevention of Sudep, such as anti-suffocation pillow, seizure monitoring devices, adenosine and opioid antagonists, and SSRI and such. So they're trying to find out how effective are these modalities to prevent Sudep. And as for the result, they managed to filter up to 4 cases at the final of the study. However, these 4 studies are at a serious risk of critical bias, and it's because they have found out a lot of bias like recall bias and many other bias in these 4 studies. So I'll talk about why they did not include all these studies as the final suggestion to prevent Sudep at the end. And this study, they reported a protective effect for nocturnal supervision, and the third study did not report any protective effect for additional nocturnal supervision. And there's no other information reported for the effectiveness of other intervention like safety pillow, SSRI inhibitor, adenosine, and opioid substances to prevent Sudep. And the final conclusion of this study is that they felt that because of this serious risk of bias, they felt that it cannot be used to be recommended as a prevention of Sudep. And that's why they recommended future study should focus on mechanism, pathophysiology, and this is one of my opinion as well, because I felt that if we can pinpoint the exact mechanism of Sudep, we can come up with different intervention to treat Sudep or even prevent Sudep. And I hope that in future study, seizure monitoring devices will be out there in the market, which are effective to prevent Sudep, because by having this, the patient will have devices to be around to help them prevent Sudep. So after describing all the mechanism and the prevention for Sudep, what can we do as a doctor or neurologist? So I found out from the American Academy of Neurology and the American Epilepsy Society website, they recommended that we should do counseling by telling them the incidence of Sudep or the risk factors for Sudep. And each counseling should be individualized because every patient is unique and special. And we should start off by telling them the incidence. And from this table, we can tell the childhood is less common, adulthood is more common to have epilepsy, but it's very hard to tell them, to make them understand about the numbers that is shown on the table. So instead of telling them the numbers on table, we make it easier by telling them, if the parents are there in the clinic, we should tell them there'll be 1 in 4,500 children in a year that will suffer from Sudep. And likewise, we need to tell them the probability of not getting Sudep, which is there will be 4,499 children in a year that will not suffer from Sudep. So by telling them the probability of getting and not getting Sudep, this will give them a better understanding of the Sudep incidence and also ease their anxiety, because they will get anxious when they don't know much about Sudep incidence. As for the adult population, we need to tell them that there'll be 1 in 1,000 person in a year who will get Sudep. And likewise, 999 in 1,000 person in a year will not get Sudep. And these numbers are very important to be told to them during counseling, because it gives them a rough idea of how Sudep occur, how frequent it occur in a year in epilepsy population. And moving on, the second most important thing is the risk factor for Sudep. And I highlighted the 3 risk factors on the left. So the 3 risk factors here are mostly on the generalized tonic-clonic seizure and not being seizure-free. And we need to tell the patient that if the patient has generalized tonic-clonic seizure, they will have 10 times increased risk of getting Sudep compared to those who do not have. And if the patient has frequent generalized tonic-clonic seizures and they have it more than 3 times a year, the risk increases to up to 15 times compared to those who does not have generalized tonic-clonic seizure. And we need to tell them that if the patient is not seizure-free for 1 to 5 years, the risk increases to 5 times, almost 5 times compared to those who are not seizure-free. And it's very important to tell them about this. And by telling them about the risk factor, we can modify it and have a better seizure control, which will help us to prevent Sudep. And just a take-home message for everyone here who is listening to my presentation. Sudep is a very big topic, and I'm just telling, I believe which is essential for us healthcare practitioners to educate the patient. And Sudep is preventable actually, and we just need to modify the risk factors like the generalized tonic-clonic seizures as recommended by the American Academy of Neurology. And by doing that, we can help the patient live a better life and just like a normal person walking on the street. And before I end my presentation, I just want to thank both of my mentors. They are right now in Kuala Lumpur, which is the capital of Malaysia. And on the left is Professor Dr. Lim Keng Siang, and on the right is Dr. Fong Si Lei. Both of them, they play a very big role in letting me explore a lot about neurology research. And that's how I started to know about Sudep since 2 years ago. And I have just completed my study on this mortality in epilepsy. I'm glad that I managed to know more about neurology research, and I hope that in the future, I can contribute more to the neurology field, being as a clinician and as a researcher as well. And I hope that everyone learned something from my presentation and it will help in your future career. That's all from me. Thank you very much.